Thank you for the mind-boggling session, Dr. Rajendra sir, Dr. Mohit sir, and Dr. Otsav sir. Now let us begin with the third session, which will be a panel discussion on lung and heart attack, that is dual attack. I would request Abhishek Kesri ji to escort the chairperson for this session. That is Dr. Rajendra Prasad sir, Head of Department, TB Chest Medicine, Eras Medical College. Dr. J.K. Mishra sir, Head of Department, TB Chest Medicine, IMS PHU. The panelists for this session are Dr. A.K. Pandey sir, Senior Cardiologist, Varanasi. Dr. R.K. Singh sir, Emergency Medicine Specialist, SGPGI, Lucknow. And Dr. S.K. Pathak sir, Senior Pulmonologist, Varanasi. I would also like to invite Dr. Swapnil to begin the session by presenting a clinical case scenario. Over to you, Swapnil sir.
Thanks a lot, Sakshi. Hello and good evening to all the respected guest faculties, professors and delegates. I'm extremely grateful and honored to have gotten this opportunity to speak in front of you all. My esteemed panelists asked to present a case on this topic, therefore I prepared it hard. I would especially like to thank Dr. Pathak, Dr. S.K. Pathak and Dr. Rajendra Prasad sir for motivating me and inspiring me throughout in the most crucial phase of my life, that is my postgraduate exam preparation. And by God's grace and by blessings of my parents, family and siblings, I was able to crack NEET PG this year with a good ranks. Now I request my esteemed panelists to grant me permission to present this case in front of you. Is it granted, sir?
Hello. This is before the case presentation. This is one of the important cases in BCG hospital. We just prepare for this presentation. This is Dr. Swapnil.
So the patient is 60-year-old female presenting to the emergency department with acute onset shortness of breath. Symptoms began approximately 2 days before and had progressively worsened with no associated aggravating or relieving factors. She had similar symptoms approximately 1 year back with acute exacerbation of COPD requiring hospitalization. She uses BiPAP ventilatory support at night when sleeping. She denies fever, chills, cough, wheezing, sputum production, chest pain, palpitations, abdominal pain, abdominal distension, nausea, vomiting and diarrhea. She reports difficulty in breathing at rest, forgetfulness, mild fatigue, feeling chilled, requiring blankets, increased urinary frequency, incontinence and swelling in her bilateral lower extremities that are now new onset and worsening. Subsequently, she has not ambulated from bed for several days except to use the restroom due to feeling weak, fatigued and short of breath. There are no known ill contacts at home. Her family history includes significant heart disease. Social history is positive for smoking tobacco use at 30 years. She quit smoking 2 years ago due to increased shortness of breath. She denies all alcohol and illegal drug use. There are no known food, drug or environmental allergies. Past medical history is significant for myocardial infarction, COPD, hypertension, hyperlipidemia, hypothyroidism and diabetes mellitus. Her current medication includes fluticasone, vilanterol, 100 to 125 mcg inhaled daily, hydralazine 50 mg by mouth 3 times per day, hydrochlorothiazide 25 mg by mouth daily, albuterol, ipratropium bromide inhaled every 4 hours urine, levothyroxine 175 microgram by mouth daily, metformin 500 mg by mouth twice per day, levobolol 5 mg by mouth daily, aspirin 81 mg by mouth daily, and further treatment like vitamin D3 and clopidogrel and isosorbide monohydrate, as she is a known case of MI and she had an episode of MI in previous years. Now I go for physical examination. Initial physical examination reveals temperature 97.3 degree Fahrenheit, heart rate 74 beats per minute, respiratory rate shows tachypnea, and BP is normotensive. Height is 160 cm, weight is 100 kg, that is very significant. BMI is 39.1, which is very obese. Oxygen saturation is 90% on room air. Now constitutionally she looks okay, but she is extremely obese. Well developed and well nourished with BiPAP in place, lying on hospital stretcher. Now head to toe examination is kind of normal. I don't think So eyes, conjunctiva, and UM normal pupils are equal, round and reactive to light. No skeletal, bilateral periorbital edema is also present on the face, which is significant. Now cardiovascular examination is kind of normal, only 2+ splitting edema, bilateral lower extremities and strong pulses in all 4 extremities. But edema is 2+ bilateral lower extremity edema, which is splitting. Respiratory examination is no respiratory distress, she is not having any distress, but tachypneic, bilateral wheezing present, decreased air movement bilaterally on auscultation. The patient was barely able to finish a full sentence due to shortness of breath. Abdomen is soft, bowel sounds are normal. Skin is very dry, neurological. She is alert, awake, able to protect her airways, moving all extremities, no sensation loss at the time of examination, neurological examination. Now I will go to initial evaluation of this patient to further elucidate the history findings. CBC to establish if an infectious or anemic source was present. Comprehensive metabolic panel to review electrolyte balance and review renal function. And arterial blood gas to determine the PO2 for hypoxia, any major acid-base derangement. Creat, probide, evaluate the presence of myocardial function or rhabdomyolysis, and BNP, ECG and chest X-rays. Now, what is significant? CMP, this comprehensive metabolic panel showed creatinine elevation above baseline from 1.08 to 1.81, indicating possible acute injury. EGFR at 28 is consistent with chronic renal disease. Calcium was elevated to 10.2. However, when corrected for albumin, the corrected to 9.8 mg per deciliter. There is mild elevation of ALT and AST in this case. Okay. Initial arterial blood gas with probably respiratory alkalosis and oxygen saturation 90% on room air, indicating respiratory alkalosis with hypoxic respiratory features. Now, creatine kinase was elevated along with serial elevated drop eye studies in the setting of a known chronic renal failure and acute injury indicated by above creat value. Probably she will go into rhabdomyolysis. Now, ECG doesn't show much changes. Normal sinuses with non-specific ST changes in inferior leads. Decreased voltage in lead 1, 3, AVR, AVL, and AVF. Now, on chest X-ray there is bilateral homogeneous opacity seen, bibasilar AS disease that may present alveolar edema, cardiomegaly noted. Prominent interstitial markings were noticed. Small bilateral pleural effusion is seen on chest X-ray. Rate of change of congestive heart failure obviously with bilateral pleural effusion greater on left compared to that, as you can see in the picture. Now, as per this clinical history and evaluation, initial evaluation, there are some differential diagnoses like acute and chronic COPD exacerbation, as she is a known case of COPD with exacerbation, and progressively in the history I will tell you that the patient is not actually compliant on her medications. Acute and chronic COPD exacerbation, acute and chronic renal failure, bacterial pneumonia, congestive heart failure, and STEMI because of those non-specific ST segment changes, and pericardial effusion, hypothyroidism, because in the confirmatory changes we will see that the thyroid profile is too delayed, TSS levels are very high, and pericardial effusion, hypothyroidism, pulmonary edema, pulmonary embolism. So these are possible differential diagnoses. Now, what we do in confirmatory evaluation, we do 3 things. One is thyroid panel, the BNP levels, and repeated ABG, CT scan of the chest, and echocardiogram. So there is one significant one. On the second day of admission, patient shortness of breath was not improved, and she was more confused with difficulty arousing on conversation examination. And that is her mentation is kind of deteriorating. To further elucidate the etiology of her shortness of breath and confusion, the patient husband provide further history. He revealed that she is poorly compliant with her medications. Right. Now, TSH is kind of very high, T4 is low, BNP is also high. Now, repeat ABG on BiPAP ventilation shows I think metabolic acidosis. Because of that, I think rhabdomyolysis, and the saturation is 90% yet on 2 liters supplemental oxygen. Echo show one significant thing: the pericardial fluid is collected primarily posteriorly. Ejection fraction is kind of preserved. Now, NCC thorax reveals primarily obtained to evaluate the left hemothorax, especially the retrocardiac area. Now, the impression is tiny bilateral pleural effusions, pericardial effusion, coronary artery calcification as it is seen. Some left lung base atelectasis with minimal AS disease. The overall clinical history, physical examination, evaluation are likely to be suggestive of kind of dual heart and lung manifestation of a particular disease. Now, I hand over this case to esteemed panelists for further discussion and enlighten us for what could be the provisional diagnosis.